Welcome, everyone. Thanks for joining me on this warm and sunny spring evening. So thankful that you're sharing your time with me. Um, so I'm Dr. Davidicus Wong, family doctor in Burnaby since 1991. Um, and I'm going to be giving you an insider's guide to this strange and wondrous place called Hospital Land. I call it the Lonely Patient's Guide to Hospital Land because I'm going to be your tour guide to the strange, weird culture of the hospital where things are not quite the same as they are outside the hospital on your sense of identity, your sense of autonomy, sense of control of what's going on, and your ability to recognize all the many people that you'll encounter in the hospital. So I really want you to make the most of your hospital stay because sooner or later, most of us will be there for maybe, hopefully, just a simple elective procedure or a diagnostic test, but sometimes through emergency, and we never know. So I'd like you to be best prepared. So along with this is a key points handout that I've put together. So that's available on the website, the Burnaby Division of Family Practice under Empowering Patients. So look under there, you can get a copy of the slides as well. In a couple of days, it should be uploaded, and a video of this will also be uploaded as well within a couple of days. But I'm glad you're here live with me because it's so exciting when we do a live performance. I'd like to introduce Leona Cullen. All of you that have been to my talks before know that Leona is my partner in this program for over a decade since we started it in the early days of the Burnaby Division. So Leona is also active in the community with the primary care networks, and she's one of the big bosses at the Burnaby Division of Family Practice Executive. And so, Leona, you can update our team on all the things that are going on in our community.
Sure. Good evening, everyone. Thanks for joining us. Again, I'm Leona Cullen. Been with the division I'm in my 14th year, which is quite crazy. But it's been a great experience working with the Burnaby family doctor. So I will keep my spiel short. I'm going to share in the chat, so keep an eye on the chat. Our website for the empowering patients that includes, as Dr. Wong said, recordings of all of our talks. If there's any topics you're interested in, you can see a recording. Some key points handouts for every topic. Dr. Wong has done a summary of all the key points and his presentations. He's very generous in sharing his presentations with us as well. So that will be the first link. If you live in BC and you don't have a family doctor, I highly encourage you to get yourself added to the Health Connect registry, and I will put a link in the chat as to how you can easily do that. Your alternative is to call 811 and they can help you get added as well. Dr. Wong is all over now. He's writing columns again, which we're really happy to see. And so his HealthWise column comes out monthly. So I'm going to share a link to his most recent column. Actually, I'll find the other one while you're speaking, Dr. Wong. I can put a couple of those articles up there. And then I just want to pitch on May 9th, there's a prescribing nature event happening at Central Park. It's on May 9th from 10 a.m. to 1 p.m. and it's free for everybody. Bring your kids, bring your dogs, bring your friends. It's in Central Park, right by the SkyTrain station. There'll be some guided forest therapy. So it'll be a very calming day. Some musical performances. There'll be some jugglers, if you can believe it. There'll also be a pop-up screening for metabolic conditions. So if you haven't had blood work done in a while, we'll have doctors there doing that. And there'll be some in-person help for you to get added to the provincial waitlist for family doctors. So if you struggle with doing it online, there'll be people at the park. Again, so that's Saturday, May 9th from 10 to 1. Dr. Wong will be there, I'll be there, and many of my other team members. So we look forward to seeing you there. And at the end of this webinar, if you've been here before, you know there'll be a brief evaluation that'll pop up at the end. So let's get everything started. Alice, I see you have a question there. I'll just quickly take you off mute before Dr. Wong gets started. Did you have a question for us, Alice?
Can you guys hear me?
We sure can.
Oh, now I can. I was just wondering. But my face is not on. We don't show other people's faces, right?
We don't. No. You'll
Oh,
just see Dr. Wong and myself.
that's fine. I thought I was doing something wrong.
No,
So,
you're good. You're
okay,
perfect.
okay. Thank you.
You're welcome. All right. You're on,
Well,
Dr. Wong.
yeah, before I start, I just want to clarify. So on the nature prescribing Nature Day, are the jugglers going to be squirrels juggling nuts, or people aren't going to be juggling squirrels, right, at Central Park?
I hope
Okay.
not, but we'll
Right.
see.
Okay.
You have to
Yeah.
show up to find out.
Okay. I'll look out for those squirrels.
That's right.
Thanks. Thanks for the update, Leona. So we are the Burnaby Division of Family Practice, whose members are all the family physicians that look after the people of the Burnaby community. So our website is burnabydivision.ca, and you'll get lots of information of resources in the community, but also some links if you don't have a family doctor, how to get on the list, so you could get the best of family practice and primary care. So why are we here? As family doctors, we care about our patients, of course. I have 2,700 patients, and I think most of my patients under 34, I probably delivered. So we've had long, long relationships. So that's one of the great pleasures of my life is this long-term, in-depth relationship with my patients from before they're born throughout their whole lifespan to my oldest patient is over 100. And we care about the community. That's why I give these talks, and I'll talk a little bit more about that. But the Burnaby Division of Family Practice is filled with physicians that are working with our partners in the community to improve the care of everyone in the community beyond just their own patients. And we care about the future, and you're part of this team of caring for our community. So again, family docs care about our patients, and we care about our community. Why am I here? When I was about 10 years old, around grade 6, I had a big flare up of my rheumatoid arthritis. And it wasn't just joint pain, it was a lot of joint pain all over, fever, rashes. It was more like a vasculitis at that time. So I was in the hospital for almost 2 weeks in the pediatric ward at the Burnaby Hospital. And yeah, it's pretty scary and strange being in this strange land where you have to wear different clothes. You don't know who's who. But it was such a relief for me to see my own family doctor come to the hospital. And it was wonderful being cared for by these really caring physicians and nurses and other healthcare providers. So that's when I was inspired that I'd like to do something like that. That I like to work in healthcare and support kids as well as grown-ups when they're going through a lot of uncertain times, uncertainty, and kind of be their knowledgeable guide to support them both emotionally as well as a physician professionally in getting them through the hardest times and helping them achieve their potential. So that's why I decided to study medicine. It's kept me inspired, and I don't regret becoming a physician. So I really appreciate it. And I chose family practice because when I completed my internship, it's like a residency. It was a rotating internship so that after that first year, we could go into family practice or go further study and to become any specialist. And so right after finishing, I did a few locums. That means covering for family doctors while they're away. And I really fell in love and got involved in the patient's stories, how they saw their life and how their health was related to it and how they're relating to the family doctor. And I found that more satisfying than treating a particular part of the body or particular system or a particular problem. And it's given me a different perspective. So as family doctors, we specialize in the individual patients and only treat conditions or disease in the context of that individual. So we treat people, we don't treat particular body systems or conditions, but we see it all together in the context of your whole life. And then I chose Burnaby because it's my hometown, because that's where I grew up as well. And my parents were still alive and living at that time. My dad's still around. He just turned 96 years old and he's doing really well. And my mom was very involved in the community till she passed away around this time of the year in 2003. But I continue her legacy of love and caring for the community as well. My brother, who had already graduated and he was an anesthetist, told me, the best place to be a family doctor is actually our own hometown because Burnaby Hospital is really unique as a municipal, and then later a city, a large urban area where family doctors were still had a lot of leadership roles and really ran the hospital at that time. So family docs not only had their own department, which they do in most hospitals, they were rounding on their patients regularly. They were delivering babies as well. Family docs would be the head of the Department of Internal Medicine, Department of Pediatrics. It didn't necessarily have to be a specialist in charge of those departments. So every family doc belonged to one other department like pediatrics, obstetrics, or internal medicine, and as well as the Department of Family Practice. So I was the head of family practice for actually many years, and and then I became head of the all the departments, the leader of the local medical advisory committee, where all the department heads met together, and eventually I was promoted all the way up to the chair of the Health Authority Medical Advisory Committee. So all the heads of the departments for all the hospitals in Fraser Health would come and meet at the table once a month as well. I was involved in medical ethics in the education and actually as the head of ethics and doing the consultations for over 10 years, doing a lot of consultations for the most difficult patients or patient situations, not difficult people, but patients that are in pretty dire straits where they're no longer able to speak for themselves. And because they didn't have any advanced directives that we'll be talking about that I strongly recommend, then family members were debating with one another with the healthcare team about what should be done, depending on their quality of life and what interventions they would have when they were no longer able to decide for themselves. So the best way to prevent some of these dilemmas is probably having these conversations ahead of time and making sure your wishes are known to your physician as well as to your family members. So I'll be sharing that with you as well. Of course, things have changed. When at the time, there were over 250 family doctors with active privileges. About half of them were delivering babies at the hospital. Now that's quite a rarity. I was one of the last two physicians that were delivering their own patients' babies at Burnaby Hospital until about 3 years ago. Now there's a rotation of doctors in the great maternity clinic. They give good care, but they only deliver on the days that they're working. So it's quite different. And family doctors used to look after their patients when they came into the hospital and had active privileges. And we'd also look after patients that didn't have a family doctor that came to the hospital and take responsibility for their care and discharge them and look after them as well. But then the hospital and health authority brought in hospitalists. Those would also be family doctors, but most of them did not have their regular practices and they strictly did the hospital medicine. And within weeks of that coming in where hospitalists were paid just to do the hospital care, and they were paid much more than family doctors being paid to do that, then about 200 of the family docs just gave up their privileges. And then that became the mass exodus of family docs from the hospitals. And that's why most family doctors no longer go to the hospital and look after their patients there. Most have given up their privileges, except in smaller communities where they still work in the emergency department and are active in their hospitals. So today I'll talk about making the most of your hospital stay. I'll just do a quick review of the four foundations of self-care because that's a core concept of our Empowering Patients program and why we have the program as well. And we'll talk about the strange place of hospital land that some of us may end up landing in. So I'll give you the insider view as a former visitor to hospital land and someone that used to spend most of my time there until fairly recently. Well, we'll go through their strange customs and how to find your way around and warn you about the things to watch out for, as all travel advisories do. I'll tell you what to pack so you're prepared when you end up in the hospital and provide at least 3 keys for a better stay if you do find yourself in the hospital. Just as our usual introduction, I want you to re-question what healthcare is. Is it the acute things in the hospital, like when you're acutely admitted at the emergency? Or is it the community care and the chronic care? Because family doctors are mainly focused on that community and chronic care. But who is the individual that provides most of your health care? Well, it's not all the healthcare professionals, it's really you. And a key concept that healthcare is self-care. And the best predictor of your future health are the habits you practice today. That's of the things that we can prevent, which is many of the things that can lead to chronic conditions and illness. But we do know that sometimes through genetics, sometimes just through bad luck, that any of us can suffer mishaps. So we know that not everyone is fully responsible what happens to them in their health, but we try to empower you to live your best life and achieve your goals. But the purpose of all our talks is also to empower you so that you can get your best care. How you could be your own advocate, or you can be an advocate for your loved one who cannot speak for themselves. So the four foundations of self-care, preventive and proactive healthcare, are what you eat, what you do, how you feel, and how you relate. So what you eat is like a healthy diet, what you put into your body, um, as opposed to unhealthy things like excessive alcohol or drugs or cigarette smoke. What you do relates to physical activity and appropriate rest. And how you feel relates to emotional well-being, managing stress, recognizing your emotions, managing the emotions, and finding meaning in your life. And then finally, how you relate. That talks about healthy relationships involving commitment, good communication, time, and nurturing unconditional love. So we see to empower patients, you need unbiased health information, which is really hard to find these days on the internet, even on the radio or television. Often it's the hot topic of the day, and often a lot of things are people trying to persuade you or sell you some product or a certain way of thinking. So we're here, we established the Empowering Patients program to the Burnaby Division just to provide more objective healthcare. So we're not in the business of selling anything except for selling self-care and supporting you to live your healthiest life, to help you manage health conditions and to get the care that you need from healthcare professionals. To get good self-care, you need good patient-doctor communication, which is one of the topics in empowering patients, and more support to achieve your personal goals. So it's not enough for doctors to say that you should exercise more or eat better. What are the supports that are available in the community, and what information do you need so you can reach your personal goals? So if you'd like to review any of those topics, we have all those resources on the Empowering Patients. There's videos of recent talks. There's even a video from about 12 years ago that I made, professionally made video, like 3 minutes, that kind of summarizes some of the funnier and key points. But we're going to go in depth on the things you need to know so that you can get the most of your hospital stay and get out alive. So here's a lonely patient's guide to hospital land. So being in a hospital is like being in a foreign country because of course you get a wristband, but that doesn't entitle you to unlimited food or drink. It actually has your name on it. It has your most responsible physician. And that's a key thing to know which doctor is supposed to be in charge because that's the one you want to talk to about the game plan. And we'll talk about the inhabitants of this strange land. So we all dress very similarly in greens, or sometimes there's other colors that looks like some kind of pajamas. Everyone's wearing a stethoscope, nurses, doctors, respiratory technicians. Even the cleaning staff would sometimes be wearing scrubs and lab coats as well. So you never know if that's really a doctor, a nurse, a respiratory technician, speech therapist, or the rest of the support team. So the key is actually our name tags. So we all kind of look the same, so it's a bit confusing. But the key is that little name tag that we have. So that usually tells you who we are. Often the nurses will just have their first name, so you're not going to be stalking them. And it'll state whether we're a physician or other allied healthcare professional, and usually the department that we belong to, a physician. And of course, in this strange land, we speak a different language. So I noticed that when I was a kid first admitted, I heard the staff talk in English, but it sounded like more like a mixture of Greek and Latin and English, because we have a lot of medical terminology that's derived from ancient languages. So we always describe things in very specific, complicated ways. And it's so important when we're communicating with regular people that we use language that they understand. We also speak in code. You probably heard of our codes. Like code blue is pretty obvious when there's a respiratory or cardiac arrest. You'll hear a big loud siren. You might see people running down the hall with what we call a crash cart that has all the medicine and the defibrillators that we might need to revive someone that's no longer breathing or someone that's collapsed. So everyone knows that from TV. A code white is usually the code for um, someone in crisis or someone that's potentially violent or someone that's very distressed. So more a psychological emergency. Code red is usually a fire. Code pink is when we need to rush to the neonatal ICU or the case room because a little baby needs resuscitation. Code yellow would be when there might be some pee on the floor, and the code brown, you can imagine what that is. So wonderful places like Hawaii, which is one of my favorite places. We used to go there for vacation with the kids when they were little, and it felt like home. Everyone spoke English to me and treated me like I was born there, just the way Vancouver and Burnaby should be. But everyone seems to fit in Hawaii. In Hawaii, there's one word, aloha, that means so many different things. It can mean hello or welcome, goodbye, and I love you. So in the hospital, we have a word that's kind of like that. Doesn't mean the same thing, but it's rounds. It means so many different things. What does that mean when we're having rounds? So doctor's rounds is when, as a family doctor, when we're active with privileges, we go around and see all our patients. Or the general surgeon will go around and see all the patients they're looking after or their colleagues are looking after. So doing rounds and looking on the patient's progress, speaking to the healthcare team and to see what the patient needs, what the concerns are. So doctors doing their rounds. Grand rounds is usually where the healthcare staff get together, usually for a lecture, sometimes sharing a particular topic of interest with one another. And team rounds is where the whole healthcare team, respiratory the RTs, respiratory technicians, the social worker, perhaps psychology and psychiatry, the attending physicians of all their specialties that are working on that ward will meet and talk about the patients on that unit. So the nurses and the doctors getting together to talk about the plan for individual patients and their progress. And brown rounds would be when I went down to radiology to kind of review a CT or X-rays with the radiologist, and the radiologists are away on coffee break. We call those the brown rounds. The inhabitants of this strange hospital land have strange customs. So one of them is the wristbands. So again, it's not like the all-inclusive resorts, but it does have some key information. So one wristband that's usually brightly colored will tell everyone what your allergies are. So make sure it does show your allergies. And if you do have serious allergies, to make sure that someone gives you that band or your loved one has that band. And the usual band will have your name on it when you registered to come into the hospital. And it usually will have the attending physician's name on it as well. And also the way we dress. So when people come, they don't get a backpack and a special hat and sunglasses. They get their hospital gown. And the reason for the hospital gown, well, it makes it easier for putting on the leads for an electrocardiogram, easier access for getting intravenous access, or for emergency procedures if those arise. But it is a little bit depersonalizing to not be wearing your regular clothes anymore, but having to put on a hospital gown. And there's different sizes, but not every size fits everyone. So make sure it covers you up well in the front as well as the back. And when I was a kid in the hospital, I wasn't really paranoid, but you can't help but feeling paranoid when you think the people around you speaking a different language in Greek and Latin are talking about you, especially when there's a binder down the hallway that has your name on it. So this is traditionally there's a big three-ring binder where orders are written, reports are placed, it has your name on it, but you never get to see it. So everyone that's looking after you will write in that book and all the lab results go in there too, but the patient never gets to see the book. So gradually this is kind of being replaced with the electronic medical record. So now they're virtually doing all these things on the computer and there's a chart with all the information related to you. So that's why people get confused, a little paranoid when they're in the hospital, especially late at night. And of course, the food. Hospital food is renowned. In some countries, a five-star resort in some countries like Mexico is not quite the same as a five-star resort in North America. So some people say it's like a three-star resort. And hospital food is kind of usually a notch down. So when you stop throwing up and start complaining that your food is like a two-star hotel, the doctor will probably think you're nearly normal and ready to go home. Although they have a few other criteria for going home too. So one of the most important things to empower the individual is to recognize that they still have informed consent. So informed consent, the informed part is making sure you have enough information so that you can agree or disagree with a course of treatment. And that could be medication, procedures, um, and diagnostic tests like x-rays or blood tests. So you need enough information about the benefits, the risks, and the alternatives of a test procedure or drug before you can choose or refuse it. But that doesn't always happen really formally in the hospital. But for informed consent, according to medical ethics, there are two keys. You need enough information, the information you need to make a decision, and the individual must be capable of understanding that information and making an informed decision on their own. So sometimes if we're unconscious, such as in a coma, if we're impaired due to illness or other reasons, if we have advanced dementia and are not capable of understanding the information or making a decision, then you need someone that's going to be looking after your interests, making those decisions. And it may be a family member, but it's preferably someone that you would have selected yourself when you were capable of making your decisions. So before the hospitalization. So as I mentioned, due to illness or incapacity, you may not be able to give informed consent. So who will decide on your behalf? So we'll talk about that in detail as well. So what are the dangers in this for? And then, of course, infection. So you've been hearing lots about that over the past 10 to 20 years. And anytime you gather sick people together and have people like physicians, doctors, other healthcare providers moving from patient to patient, there's a risk of passing infection from one person to another. So that's why we really enforce careful hand sanitizing and washing and proper clothing and protection like gowning and gloves and caps so that we don't spread infections of any source from patient to patient. So you can acquire infections like pneumonia in the hospital. You can get skin infections like Staph aureus. So MRSA is just a particular type of bacteria in the skin. We commonly have streptococcus and staphylococcus on our skin, but often in the hospital, because people are given different antibiotics, some of those Staph aureus strains are resistant to the usual penicillin type antibiotics like methicillin. So that's what MRSA is. It's not a superbug, but it's a medication. It's a type of Staph aureus or a strain that requires antibiotics that are different from the typical penicillin type drugs. So they're still treatable. You can also get C. difficile diarrhea. So that's an opportunistic infection that can arise when someone's been taking multiple antibiotics. They can get this terrible diarrhea that smells especially bad. So nurses are well known for being able to recognize it just by the smell itself. So we've done lots of things at all of our hospitals to reduce the spread of infection. So infection rates are actually decreased quite a bit from 10 or 20 years ago. We're always on the alert to make sure nothing is passing around between our patients. Also, there could be complications of procedures. You can get bladder infections from the catheters that we might put in when the patient has some difficulty with urinating. You can get infections or bleeding after surgery. That's a common risk and complication. If you're having difficulty swallowing or you're not fully conscious, then you can reflux and aspirate some food from the stomach if you throw it up, and that can cause a type of pneumonia as well. And then, of course, if you're lying down all the time and not moving, you'll get bed sores, like skin ulcers from the pressure points. And of course, all procedures and all medications have potential side effects. There's also the potential for errors when so many people are looking after you. We can miscommunicate, like not write an order that's clearly legible, so there can be mistakes along the way. You might get the wrong dose of medication or wrong drug, or there might be the wrong patient. So when family doctors were normally rounding with their patients, we would often pick up lots of these little mistakes and errors that can pop up and correct them. But it's hard when you're not sure if you actually have an advocate in the hospital with the exodus of family doctors at the current time. But the hospital does have a safety-based culture where all healthcare staff are encouraged to report errors and near misses in a blame-free environment. So we know that if a wrong medication was given, it's not necessarily the nurse's fault. It could be because the handwriting was not legible or confused because of the terminology or the name of the drug could be confused with another. So we've taken lots of steps to kind of standardize orders so that they are clearly legible and not using abbreviations that are easily confused. So we always look into errors in the hospital in our efforts to reduce those errors from being repeated. So that has improved a lot over recent decades in the hospital. So how can you prepare for your hospital visit? You probably heard that old advice that my mother always said, always wear clean underwear in case you're in an accident. My mother never said that because that's kind of ridiculous. Because if you're in an accident, don't you think there's a good chance you might poop or pee in your pants anyway, even though you started off the day with clean underwear? So I think better advice would be never miss an opportunity to go to the washroom because you never know if you might be in an accident. So you don't want so much poop and pee in your underwear. But if you're going to be in the hospital, don't wear your best underwear because really in emergencies, we end up cutting them open, like cutting open your Under Armour t-shirt in order to access your heart if you need defibrillation. But if it's an elective hospital visit, or you end up in the hospital and you want to know what your family should bring for you from home, you definitely don't want to bring a lot of valuables. The key thing to bring, like you travel to any other country, is essential documents. And that's the essential medical information that we would want, your family doctor would want your care team to know. One is your medical history, and that should include any allergies you might have. Food allergies as well as allergies to medications or adhesives, because we use a lot of adhesives as well, like for bandages and securing IVs and other things that you might need. We need to know your chronic conditions, such as diabetes or high blood pressure, congestive heart failure. So that's really important for that to be listed in your one-pager medical history. Significant past illnesses like my hospitalization when I was a kid and the reasons for that, and any major operations that you have. That would be really useful to know. Other important aspects of the medical history is your family history, particularly first-degree relatives like your mom or dad, and your siblings, grandparents, if you know that history. So, what medical conditions did they have? Did they have particular types of cancer like colon cancer or polyps? Is there family history of breast cancer, bladder cancer? Is there family history of metabolic conditions such as diabetes or high cholesterol or high blood pressure? So those are really useful things to inform your healthcare team. And that all that could be summarized on just a single page. And if you don't have all of that information at your fingertips, you could ask your family doctor because we have that as part of your regular hospital chart, office charts as well. But as a family doctor, if a patient doesn't have these things already written down, then we can print out a little summary of their health history. You would also want to keep a list of your medications that you regularly take. So a lot of patients only remember the first 3 or 4 letters of their medication, but unfortunately, most of the time, that's just the prefix for a generic drug company. So, uh, like Nova could be a prefix for a generic company, and what comes after that is actually the actual drug name. So look very carefully, and if you're not clear, you can ask the pharmacist or your physician, what's the full name for this medication. So you should know the name of the medication, the entire name. What is the dose in milligrams or micrograms? And what are the directions for use? Is it taken once a day, twice a day, or just at bedtime? And the indication means what is the reason? So what's the medical condition that, or the symptom that the medication is treating? So I'll give an example. So an over-the-counter name brand medication is Tylenol, but the chemical name or generic name of Tylenol is acetaminophen. You can tell that the name brand is usually more catchy and capitalized, and the generic name is not capitalized, but a little bit harder for people to remember and to spell. The dose for a regular Tylenol or acetaminophen tablet is 325 milligrams, and the directions would be one tablet twice a day for some people. Some people would be one tablet every 4 to 6 hours as needed. And the indication is a reason for taking it. And in this case, it's for knee pain. An example of a prescription brand name drug is Altace, and its chemical name or generic name is Ramipril. And the dose could be 5 milligrams, 2.5, or 10 milligrams. And it could be one capsule taken once a day in the morning or at bedtime. And the indication is for high blood pressure, although this drug is also used for congestive heart failure. So those are the key things. The name brand, if you have it, and if you're taking a name brand, but the most importantly, the generic name, the dose in milligrams, and how many times a day is it taken, and when is it taken, and when it's for. So if you don't know that, if you have one or more drugs and you don't know the reason you're taking it, it's really important that we provide you that information so that you have that in the medical one pager that you have in your wallet or in your purse if you arrive at the hospital. The other essential medical information would be what your preferences are. And the older we get, the more we should be thinking about this. So it's really important if your religious beliefs would affect what kind of procedures you would have and what type of interventions you would refuse. For example, people that belong to the Watchtower organization uh, would not want to have any blood transfusions because that would be against their spiritual religious beliefs. And we wish to respect that. So if you have religious beliefs that would preclude certain types of treatment, it's really important that you carry that information with you on your person all the time. And an advanced directive looks at what you would want done and what you would not want done in the future if you couldn't decide for yourself. So it's best to think of these in advance before you're ill and while you're still capable of making your decisions. So in short, it's a statement of your preferences for medical care that others can refer to when you're not able to make your own decisions. And it could be something that's more permanent or temporary that makes you unable or incapable of making your decisions. So what procedures would you want to have, and what procedures would you not want to have? And what are the conditions where you wouldn't want to have it? For example, if I had a major stroke and with no chance of recovery, and I couldn't breathe on my own. I couldn't communicate and I couldn't recognize my loved ones or speak or express my feelings. Or if I was completely unconscious with no chance of recovering, I would not want to be defibrillated with the paddles on my chest to start my heart if it were to stop. And I wouldn't want to be intubated and then potentially being on a machine, a respiratory machine to sustain my breathing and keeping me alive. However, if I had a more reversible condition or a good hope of recovery, I may want all these procedures done, especially if I'm younger rather than 80 or 90 when resuscitation is less likely to be successful. It may prolong suffering. So it depends on your preferences, but it depends on the conditions as well. So what would you choose and what decision would you make? Because that should be expressed in writing if you're able to. So that's that example. If you had an irreversible condition that's going to lead to death with no hope of return to an acceptable quality of life from your perspective, not necessarily someone else's, you might not wish to have chest compressions, assisted breathing, intubation, or defibrillation. So that's usually what we mean by CPR, cardiopulmonary resuscitation. It's the chest compressions, the assisted breathing, either with bag and mask or oxygen. And intubation means a tube going down into our throat or sometimes our nose, but mainly down the throat into the trachea so that we can assist and blow the air into your lungs. And defibrillation is putting on the paddles to shock the heart to come back from asystole or an irregular, potentially life-threatening rhythm. So if you were in a persistent vegetative state with no hope of recovery, you might not wish to be on mechanical life support machines. So the keys are to plan in advance. That's why we call them advance directives. Talk it over with your family and friends, the people that would be worried about these things and be asked to make those decisions if you weren't able to make those decisions yourself. Choose someone, preferably one person you would trust to respect your preferences, and also a backup person who would, if that person were not available, who you would trust to respect your preferences. And then once you've had that discussion and talked about your preferences, to inform your family doctor and to put it in writing. Because there's ways that we can document that and make it available if you ended up in the hospital or having it handy on your person so that it could be referred to. And it's something to review pretty regularly. So as we get older, it becomes more important to consider advanced directives and actually put them into place so that your family members know what you would want in different circumstances and they know who's going to be respecting your wishes. So if you'd like to learn more about advanced directives, a good resource is the My Voice document. So the link to accessing information about advanced care planning, you can see the key points handout that is being posted on our website. And I'm not sure if Leona can put the link in the chat as well. This is another document that many of us are discussing with our patients in the office. So when you end up in the hospital, this is pretty well completed for every adult that gets admitted to the hospital. It's called a medical order for scope of treatment. So what it is, it kind of is the outcome of discussions with a patient, that the patient is capable and alert and can make their decisions, or the patient's substitute decision maker. So that might be their spouse, or if the spouse is not available, with their child or other members of the adult members of the family to discuss. So I'll go over what this form actually covers. The first decision is, would you want cardiopulmonary resuscitation? As I mentioned a few slides earlier, that means if your heart or lungs stopped or you went into a potentially fatal heart rhythm, would you want us to defibrillate, use the shocking paddles to do the CPR, the chest compressions, to give assisted breathing with bag and mask or through uh, uh, laryngoscopy tube or a tube down your throat, your larynx to breathe for you? Or would you choose do not attempt CPR? So that's the first decision. As we get older, it becomes less likely that those procedures be successful. So someone in their advanced age and they're quite frail in their 80s and 90s, if you were in a condition where your heart stopped or you stopped breathing, it's not likely that these measures be successful. They might get the heart rhythm back and help you to breathe on a machine, but it would be very difficult to wean you off and stop the machine such that you'd be able to get discharged to a quality of life you might enjoy. So most very elderly people would probably choose not to have CPR, but have that discussion with your physician while you are well, so you can make that decision in advance. Otherwise, if there's no order, and if a family member called 911 ambulance came and you weren't breathing, or your heart had stopped, then they would be obligated to attempt CPR. And it could be quite traumatic to family, traumatic to your body as well. And you may or may not recover to experience a good quality of life after. So talk more in detail with your doctor if you're not sure if that's something you would choose. And then the next decision would be choosing the level of healthcare. So there's M1, 2, and 3, and then C1 and C2. So C refers to the intensive care unit or the cardiac care unit. So that's more monitoring, and it may involve some more invasive procedures as well. So I'll take you through each of those. So M1 is comfort care and symptom control. So an example of someone that might choose that would be if I was at the end of my life due to advanced age and frailty, my chronic conditions, if I had congestive heart failure at its end stage or emphysema at its end stage, and there was nothing that I wanted to treat, then I might choose that. If I had terminal metastatic cancer that was no longer curable, I might choose comfort care, like pain management and symptom control. However, if you had a condition where you would want to treat reversible conditions, such as um, treating symptoms or infections, such as pneumonia or a bladder infection, then that would be M2, where you'd actually be open to using antibiotics, or if you fell and fractured a bone, like your hip, that you would be willing to go to the hospital and get surgery to repair. So with M1 and M2, you wouldn't actually be moved to a different site, like from home to hospital or from long-term care to the hospital, unless it was needed for controlling the symptoms or treating the reversible condition. M3 would be getting admitted to the hospital or a higher level of care for the medical treatment, but not M3 means not necessarily ICU or CCU. C1 would be the critical care unit, ICU or cardiac care unit, but without intubation, where you get a breathing tube put into your trachea. Critical care C2 would mean allowing intubation. So that's the difference between C1 and C2, putting that breathing tube down, because that usually would lead to being on a breathing machine. And then the other section would be what kind of discussions were made. So this is completed by the physician at the hospital or by your family physician in the office after a discussion. And it's something usually we discuss with the patient and give them some time to think about it, talk it over with their family too. So they can indicate at this time, and it's dated when we have the discussion and dated when the doctor signs it. It should be reviewed if there's any change in your condition or if you change your mind. So again, first decision is, do you have CPR or no CPR? And the second would be, what level of care? Would you be staying at home, in the nursing home, or in the hospice in end-of-life care? Or would you be willing to go to the hospital? And then would it be the intensive care unit and uh, intensive care unit plus that second level C2 if you would accept intubation? So that's called the medical order for scope of treatment, the most form. So consider having that discussion with your family doctor, especially if you have quite advanced chronic conditions or advanced age as well. Of course, I change my definition of advanced age the older I get. So I would think if you're in your mid to late 60s, you should think about this. But certainly if you have any chronic condition, um, like heart disease, congestive heart failure, if you've had a heart attack or on medications for vascular disease, have the discussion with your doctor about the most form or in scope of treatment should you end up in the hospital. Of course, there's simpler advanced directives, like you could take a Sharpie if you're going in for surgery on your right knee, then you might write this onto your left knee, not this leg. If you're here to get a inguinal hernia repaired, then you might want to put a little Sharpie just to make sure they don't give you a vasectomy by accident. The other way you can prepare is knowing what to pack, like comfort items. So it can get pretty chilly in the hospital, so you should hopefully, they do have extra blankets, but maybe if you have a comfort blanket or an extra blanket, but not your favorite one, perhaps a sweater, but not your favorite sweater in case you get cool. Of course, your own toothbrush and toothpaste would be nice. Maybe some warm socks if they don't provide any. And slippers only if they're non-slip slippers. So when you shuffle to the washroom, then you have some extra protection for your feet. Maybe some reading and word puzzles when you're bored and waiting for the doctor to come. And music. So in any form, but don't bring your latest favorite iPod or MP3 player. And of course, you probably need some earplugs so that if someone is snoring in the next bed or all the noises that occur because things are happening all the time, even when people are trying to sleep, they can keep you awake. It's really useful as we get older, just because it's when you're not going to work or school and you're just lying in the bed all the time, it's hard to keep track of the days. So it'd be really nice to have a calendar so you can kind of check off the days, you know what day it is. Because these are the very questions that a doctor is going to do to assess your cognitive function. Now, what is the day of the week? What's the date? What's the year? What's the season? Where are you? What floor are we on? These are some of the cognitive tests we check to see if a patient has dementia or delirium. And if you don't have a calendar to look at or a clock to look at, it's hard to remember if it's morning and night if you don't have a window to look out. So for communication, I recommend that there's a pad of paper, pens, your glasses if you need it, hearing aid if you need it, and of course your teeth if you don't have your own. What you shouldn't bring, as I mentioned, would be expensive prized items like your best jewelry, favorite rings, even your wedding ring. You may not, might want a loved one to take that home so it doesn't go missing if you have to go for an operation or a procedure or an MRI where you should be wearing rings. Um, you wouldn't want to bring expensive electronics, your wallet, purse, credit cards, or any of your nicest clothes or shoes. So don't bring anything that could be stolen because that can happen to anyone from other patients or their patient's family or visitors. So things disappear all the time or accidentally get thrown in the laundry and are never found again. So don't bring any of your valuables. And don't bother with cologne or perfume or makeup. So even if you think the nurse or doctor or other healthcare provider looks really good, because a lot of patients are going to be sensitive to perfumes and smells. So 3 keys to a better hospital stay when it eventually happens. So stay in control, and I'll give some tips on being your own advocate. Know your team, so knowing who is who, and setting up a channel of communication so you know what's going on with you and what the plan is. So there's 4 things you need to know to stay in control, to maintain your autonomy. And there's 4 keys that you need to know about every test, procedure, and treatment. And I know for sure that patients aren't asked or informed of these things. So the purpose or the reason for this test or treatment or drug. What are the common side effects or risks from this test or procedure or drug? And what are the serious side effects or risks? So the common side effects, as well as the really life-threatening or serious side effects or risks that you would want to know about. And what are the alternatives? So to investigate or treat this condition, are there any alternatives besides this invasive procedure to try to get at the diagnosis? And ask for each person's name and role. So don't be shy about that. It's like meeting new people at a party because you're meeting them for the first time. You should ask, who they are if they don't introduce themselves, because it's hard to read the name tag. So is that person wearing the scrubs and the lab coat, wearing the stethoscope, is that a nurse, a respiratory technician, or dietitian, or a speech language pathologist? Are they a physician? Are they a particular specialist, like a surgeon, a hospitalist, or an internist? And who is the attending physician or the most responsible physician? We call them the MRP. Doesn't mean they're more responsible than any other healthcare provider, but it means it's the person that's in charge of directing your care. If it's the hospitalist team, then it might change through every cycle and rotation as well. So it's really important to know who you can speak to if you have any questions, especially answering those 4 questions about every test and procedure and medication you have. While you're lying in bed and not doing word puzzles or reading, prepare your list of questions because sometimes when we pop in and do our rounds, like this case here, the doctor's doing his rounds really late at night or really in the morning when the patients are sleeping because it's obviously more efficient, but then we can't provide information to the patient and we can't answer any questions. So it's really important that you ask the nursing staff when you can expect the attending physician to come by doing their rounds to visit you so that you can ask those questions. And setting up a channel of communication. So actually many of our hospitals have a whiteboard that actually shows what the plan is, what the schedule of tests or procedures for this week or the day is. But it's really helpful so that the healthcare team can write down the results of the tests that you have and how long they think you'll remain in the hospital, what the plan is right now, what's the working diagnosis for your condition. So these are really important things that you need to know so you're in the loop and you can give feedback and ask questions. So if there's no whiteboard in the room or you're not invited or given any pens to write on it, it's really useful to have a large pad of paper at your bedside so you can leave a note for your doctor and leave questions as well. So that's an example of the whiteboard at Burnaby Hospital. And they even indicate, who's written the notes. Is it the social worker or the speech language pathologist, speech therapist, occupational therapist, the physio, or the nurse? And communication. So make sure your family doctor knows you're in the hospital, even if he or she does not have privileges, which they probably don't. We can provide necessary information to the hospital from the medical record that might be useful for that admission as well. So that's really important to actually a lot of patients sometimes call me from the hospital or call when they're waiting in the emergency department and even after they've seen the doctors just to get my opinion and I could provide some advice as well. All of us that work in the hospital really want to be centered on the patient. So this is kind of a tree that healthcare providers kind of got, their wishes, recognizing that each patient's strengths and incorporating them into the care plan. So these are thoughts from the care team at Burnaby Hospital, how they're trying to improve the care given to patients. So my three wishes for you are that you be happy, healthy, and be prepared. And that if you eventually end up in the hospital, that you'll have our key points handout. You'll have your medical history in front of you, the list of your medications. And as we get older, have chronic conditions, have some indication of an advanced directive like the MOST form or maybe the another document that tells healthcare providers what you would want done in different circumstances and who to call to be your substitute decision maker. And again, we're all here to look after one another. And that's the big point why Leona and I am here with the Empowering Patients program, so that you are part of this expanding circle of care and part of the caregivers for everyone that you know. So I'm sure there's key points here that you would like to share with your loved ones. So that's why we provide you with the slides and the handout. So please share with all your loved ones and have those conversations if you're at the point of life that you should make your wishes known to your family physician and to your family as well, what you would like in different circumstances. So I'm going to stop the share just in case there's any question.
Hello, I'm here.
Yeah, welcome back.
That was a great talk. Thank you so much, Dr. Wong, as always. We did have a question, so if you have any questions, we do have a fair amount of time, so pop them into the chat for us. But the one we've got is medical order. Is that a form you'll fill out before you go to the hospital for a scheduled surgery?
They usually don't. They actually usually don't. And that's only part of it. It's the most MOST form. So it's a medical order for the degree of intervention that you want in the hospital. So it's actually completed by the physician. So some people will do that in advance, even if they're not planning any elective procedure. Because if you're older, like you have to be careful how you define it, I guess past 65 or if you have advanced chronic conditions or any life-limiting conditions that you talk about this type of form because your physician would have that and can print it out and start the discussion and then let you go home and discuss it with your family and friends. So it's useful to have that, but that's something that's usually done in the hospital for most adult patients and usually with discussion, but you might end up in the hospital and not be awake or aware enough that you can give that conversation that they end up talking to a family member, maybe a random family member that shows up. So you want to make sure it's that family member that you would want deciding for you.
Right. So Craig is asking, not hospital related per se, but how often do you find patients using artificial intelligence to either give them a preliminary diagnosis or to help them understand medical language, etc.?
I think most most people that use the internet will probably do that, and they may not even know they're doing that. They'll do a search or they'll put in their symptoms, and then it's actually AI that kind of scores all of the internet, things that might be true, some things that might not be true, so they'll give you some information and some advice. But because it's actually looking all over the internet, it doesn't necessarily judge what's objective and what might be appropriate to you. So it often will give you a good ballpark, something similar to if you went into a room and asked a whole bunch of other people what they thought, it'll probably give you a kind of a summary of what the consensus was, but it may not be the best advice. But you can use that kind of a cornerstone, but you wouldn't want to seek out and try to order that medication or procedure online. So do seek a health professional that will fine tune medical knowledge to your desires and needs.
Right. So Marilyn, great question. It is a lot of information. So I'm really pleased to say that, as Dr. Wong mentioned, the recording of this session will be up. I'm hoping tomorrow, but for sure by Monday. And the presentation that he shared will be available and printable or downloadable, as well as a high-level key points document. So all of this information will be available on our website. And I will just say that the last question of our evaluation is if you'd like to get more information or want to be notified by me about upcoming talks, and then make sure you put your email address in there. So I'll add you to our mailing list, and we'll be able to share all this good stuff.
Oh, there's a question about food in the hospital. Do you have a choice?
Food.
Is there a menu? Actually, when I was a kid, there used to be a menu. They actually would have these little sheets that you fill out and you can circle. I think so. I really loved that because I was still growing, so I would like circle everything that I looked
Hmm.
really yummy. And so I actually liked hospital food at that time. But after a week, I really missed my mom's food, so she was bringing in lots of food for me, visiting me like pretty well multiple times a day, staying the whole day with me. So. Um, really appreciate my mom with all that loving care too.
Hmm.
So I'm not sure how much choice you have. The doctor sometimes will give an order. This is pretty well the only time that patients are following the doctor's orders about diet, like a low salt diet, because it actually can be written as an order, or a diabetic diet. So it kind of limits the glycemic index and unrefined sugars in the diet. So maybe not your choice because it actually depends on the doctor's orders, but I think you have some menu choices within those limits of what's medically indicated. Yeah, it's the only time that doctors can control what patients are eating. Usually just give that advice. But the funny
Sure.
thing is, so if I'm as a family doctor, when I request blood testing of a requisition to a patient, I actually talk about each of the tests. So I'm going to put something on that requisition that I have not discussed with the patient. And so I kind of explain to the patient that this ALT and this gamma GT, that's to check your liver function. And the GFR creatinine, that's checking your kidney function and why I'm testing it. And TSH is checking your thyroid. CBC is your blood count. So I explain why I'm doing those tests. If I'm ordering something like for HIV or hepatitis B and C, then I explain to the patient why we're checking it, and they can decline or not want to get that test done. So that's quite appropriate. I actually have a lot of physician patients that ask me, don't order the fasting blood sugar because they know it's going to be high and they don't want it on their record. So I have to comply and not order that test. But that goes for any patient, whether or not they're the physician. If it's a test being done on you, we need to do consent because actually, ethically, the Canadian Medical Protective Agency that advises us what's ethical, non-ethical, and not legal, is not ethical to do an HIV test on a patient without their consent. That can be considered battery. But pretty routinely, blood tests are ordered on patients, even a competent, capable patient, and they don't necessarily know all the tests that are ordered for them. Like pretty well every um, female that is of reproductive age comes in with abdominal pain, pelvic pain. They always do a pregnancy test. They always do a urine or blood pregnancy test on that patient, and they may not necessarily have asked. So that's a funny thing about the hospital. It's the same standard of medical ethics, but the custom is for you not to be told actually all the tests that are being done on you, but you have a right to know what they are, and you also have a right to refuse the blood test. but
Right.
bad things can happen if you are labeled a non-compliant patient in the hospital.
Mhm.
And then I've even had a patient that, against special advice, decided they didn't want to stay and they left, and then they write down left against medical advice.
Right. Okay. I'm not sure if you saw this question. Uh, they say, wanted to remove my terminal husband from hospital, family doctor and heart doctor on Christmas leave. What would have happened to me?
Is that a real case? That
I'm not sure. So it was in our Q&A section. I don't know if you can access that,
oh,
but yeah,
I did.
wanted to remove my terminal husband from hospital, family doctor and heart doctor on Christmas leave. So I'm thinking that maybe she wanted to take her husband out for Christmas.
Oh,
And perhaps the doctors didn't support the choice. I can't really say.
uh,
I
yeah,
mean,
that's kind of tricky. Yeah, the attending physician, if it was hospice or the hospital, would
right.
often you would, if the patient was fit to go for a day pass, then that would be allowed. This is to make
Yeah.
sure that that's safe and you have enough supports.
Right. I'm just wondering because if she says Christmas leave, so perhaps it was a bit of a longer
Yeah, but there's always
time as opposed to
yeah,
a day pass.
yeah, but if someone is in the healthcare facility, nursing home, hospice, or a hospital, there has to be someone that the doctor would be filling in. So someone has to be looking after the patients.
Right.
So yeah, if I wasn't able to look after my patients when I was away from hospital and they're admitted under my name, then I'd have to get someone to cover for me so they would still round and approve like a day pass, for example. So there always would
Right.
be someone that can give that permission.
Right.
But if you
Okay. Well,
took
hopefully that was
someone, yeah,
helpful.
yeah, if you took them out against medical advice, they would say against medical advice. And
It would just be noted, documented.
I don't think you go into jail, though.
Hmm.
Yeah, I don't think it'd be considered a crime unless it was against what the patient's wishes were, but that doesn't apply here.
Oh, we've got some clarification. Nobody suggested a day pass, so it wasn't
Oh,
offered as an option.
yeah, it depends on the circumstance of whether it'd be safe to leave, but sometimes it might be better to. I had a patient. So she had terminal cancer, but her favorite time of year was Christmas. So the family it was July, so the family had put up the Christmas tree, put up the decoration, so we can let her go home and spend Christmas with them in July before she passed away. So that
Mm,
was pretty magical what that family did for her.
no doubt, no doubt. Well, Christmas is my favorite time of the year, so I'll remember that. Excellent. Well, anybody else have any questions? We have unique access to Dr. Wong, and I will also share that Dr. Wong has agreed. This is our last session of this season of Empowering Patients, but we are going to plan for one that'll start again in September. And I think we're adding a new topic to the rotation. So we typically, Dr. Wong will review the subject matter for our topics. We'll pick them. We usually do 7 or 8 within a year. But he's going to create a new one for us, and then we'll be doing updated versions of some of our other topics. So stay tuned. If you would like to receive information on that, be sure to include your email. If you already get emails from me, you don't have to include it. But if you want to, just add your email address into the evaluation form for the final question, and I'll be happy to keep you up to date on all that stuff. And Craig's asking, how often do doctors use AI?
Actually, a lot. So actually, a lot more physicians are using AI that is actually writing the clinical notes while you're talking to the patient so that you can focus on the patient. So it's basically dictation software that's just organizing the information in the chart like the doctor would. So it's recognize the language and then transferring it into the medical note. And then the physician will read over the note to make sure it's all the details, the key details, and makes corrections to it. So that's becoming more and more kind of the standard or the norm now. So that's medicine in the future. We, most of us don't rely on AI to make the diagnosis though, so we're not at that level yet. But I think it would be useful as AI gets better at diagnosing and putting, as long as the information source is actually verified, peer-reviewed medical science, then it could be very helpful to think of things that we're not thinking of. So using it that way could really supplement our diagnosis, but the final kind of diagnostic impression decision and the plan that we offer to the patients belongs to the physician, and physician takes final responsibility for that.
Always humans last. Just one more question. I have never spent hospital stay for 50 years. Why no face washing or brushing teeth?
So I'm not sure that means,
So I guess so she hasn't stayed in a hospital for 50 years. So why no face washing or brushing teeth? You're allowed to do that in the hospital, right?
yeah, yeah,
Okay.
yes. Yeah, you definitely you want to brush your teeth
Yeah, that's
and
fair.
wash your face and
Okay. Hopefully that
uh,
clarifies that for you, Joy.
yeah, as long as you're capable, of course. If
Right,
you're on life support, you probably won't get your teeth brushed. But
right,
they always have swabs because the mouth gets so dry.
right.
Yeah, so they always have swabs and provide proper hygiene.
Okay. Well, she said, but no help from staff. So probably the same. It would depend on sort of your level of capacity to be. Sometimes you can do those things yourself,
Mhm.
and then sometimes the staff would be able to be there to support.
I don't know. I haven't been in hospital for so long that, yeah, because that wouldn't be a job that the nurse would be doing and
Right.
care aid staff. Yeah, that's a little bit beyond the cleaning staff.
Yeah. Yeah. Exactly. Awesome. All right. Well, we've covered it. Thank you for the kind words and the chat there. And anything else, Dr. Wong?
No, it's yeah, pleasure and honor to spend time with you. Still a little
Hmm.
bit of sunlight. The sun's not fully set, so yeah, if it's safe in your neighborhood, and you haven't gone for a walk today, have a quick walk and
Hmm.
enjoy your evening and be happy to see you in May. When we're prescribing nature, we'll figure out if it's juggling squirrels or squirrels
That's
being
right.
juggled, or
That's the mission.
it better not be. I'll put a stop to it if they're juggling squirrels.
Okay. That's great. All right. Thanks again. Well, hopefully we see you in the fall, folks. We'll see you in May. Sounds great.
Okay, take care, everyone. Stay
Thanks.
healthy.
You too. Bye-bye.
Bye.